Good morning, everyone. A warm welcome to all the dignitaries and participants for joining us from all across the country. I am Dr. Shilpi, working as medical scientist in the Icmr Bioethics unit, and I'll be moderating the sessions for today's program. It is indeed a great pleasure to welcome you all for an update on Icmr National Ethical Guidelines with special reference to epidemiological research. And I'm very grateful for taking time off from your busy schedule to attend the program. As we are all aware, the ongoing COVID-19 pandemic situation has presented with plethora of novel challenges, and research needs to be at the forefront to battle these robust challenges. Epidemiological research is of prime importance and deals with mapping of health and disease in populations with use of different study methods and tools on a large number of research participants in a single or multiple settings. There are a lot of ongoing registries across the country, and specific ethical issues emerge from the scientific merit, design, and implementation of such research. Therefore, the primary objective of this program is to train the members of the Ethics Committee and to bolster epidemiological research. Today, we have an esteemed panel of experts who have joined us for an academic feast. Today's meeting will be chaired by Dr. Vasantha Muthuswamy. We welcome you, ma'am. But before we move further, I have a few administrative announcements. So participants are requested to keep themselves muted, and any queries may be posted to us in the chat box. In view of the overwhelming response, we have tried to incorporate as many participants, but kindly note that the certificate will be awarded or issued to only the Ethics Committee members who attend the program in entirety. So now let's cruise along with the proceedings of the meeting. I take immense privilege as I introduce the first speaker for today, Dr. Prashant Mathur. Dr. Prashant Mathur is Scientist G and Director of Icmr National Center for Disease Informatics and Research. Since May 2018, our center is involved in research on epidemiology, patterns of care, and survival studies on cancer, stroke, cardiovascular diseases, diabetes, and the risk factors. He has initiated several major projects of Icmr, worked with WHO, and was nodal officer of Icmr international collaborations with the MRC UK, CIHR, and Global Alliance for Chronic Diseases. We welcome you, sir. Now, I would hand over the session to Dr. Prashant Mathur and request him to give introductory remarks for the training. Over to you, sir.
Yeah, thanks, Shilpi, and good morning, everybody. On behalf of the family at Icmr National Center for Disease Informatics and Research, I welcome you for attending this webinar on National Ethical Guidelines with special reference to epidemiological research. NCDIR, as it is known in short, deals with a lot of research work which is related to the epidemiology of non-communicable diseases. And so we thought that we would be an appropriate forum to have such a webinar in place. The institute was set up in 2011 as one of the permanent institutes of Icmr, and the purpose of the institute is for creation and maintenance, development of a national database through use of advances in electronic technology with a national collaborative network to address non-communicable diseases, their risk factors through epidemiological, clinical, and public health research. The Icmr Bioethics unit is also at NCDIR, and thus the reason for this workshop. The major non-communicable diseases that we deal with are cancer, stroke, cardiovascular disease, and diabetes. And we are very well aware that we need to align our research with the overall national efforts towards non-communicable disease prevention and control, disease surveillance, monitoring, and evaluation, using the IT and digital technology under the research governance framework following ethics and regulatory laydowns, and linking this evidence generation to action, but also simultaneously training and capacity strengthening in these areas. So as the name of the institute suggests, disease informatics, just to give you an idea, as the best definition that was given for this disease informatics is the application of information science in defining diseases with least error, identifying most of the targets to combat a cluster of diseases, and designing a holistic solution to the problem. Disease informatics perfectly aligns to non-communicable diseases, which have a multiple risk factor approach and influence one another, unlike many other vector-borne diseases where there is a single agent and there is a single host. So disease informatics basically looks at outcomes, whether it is disease or death, and looking at the causal chain of component causes. To be effective, the good features of an informatics system should be that it should be acceptable, adaptable, novel, and at low cost, and should be guided with complete data, concise presentation, concrete information, clear guidelines, correct actions, and considerate to system users and to the population. We are very proud to say that we host one of the largest networks of research institutions in the country. I am not aware of many more institutions. We deal with almost 600 medical colleges, research institutions, private sector, NGOs across the country in the length and breadth of our area of research. And many of our research programs are going on for several decades. So these are not merely cross-sectional studies of one time, but these are very long-term investments that we have made. To give you a glimpse of the kind of work that we do in the area of cancer, we are known for running the National Cancer Registry program, which started in 1981, and we are doing very well with more than 270 centers joining us. We have several programs within the cancer registry and the cancer program. Then we also have registries on heart failure. We are also dealing and working on strengthening the medical certification of cause of death. Stroke is another area where we have population and hospital-based registries. We do undertake a lot of surveys on non-communicable disease risk factors and health systems work, and also doing some burden of disease estimation. Our strength lies in our statistical and IT team who develop and provide a lot of softwares which are in-house. We provided free of cost to all our collaborators and partners. And yes, the bioethics unit over here, which is a WHO collaborating center for strengthening ethics in biomedical and health research. We also will be telling you more about the work of bioethics in the coming presentations. So I will be speaking a little more on registries because that is one form of epidemiological research. The other kinds of research, we will have another esteemed speaker, Professor N.K. Arora, who will speak on the other study designs. And because we deal with a lot of registries, so when we set up this program, the idea was to engage with the ethics committees of institutions where we run our registries, whether it is cancer, whether it is heart failure or stroke or mortality. And that is why most of you who are logged in belong to one of our registry work, and we are very thankful to you for supporting our work. You may be facing difficulties or in understanding and the ethical issues and even the science behind the registry functioning. And so we thought it would be better to just give you a brief explanation of registry. It's an organized system of continuing systematic collection, storage, retrieval, analysis, and dissemination of information on the occurrence and characteristics of persons who could have a particular disease or a particular condition or a risk factor or prior exposure to any substance or circumstances. The continuing activity is the main feature that distinguishes a registry from a survey. And this is just not a catalog registry where you can just catalog the information like many other registries you would have heard about, but this is something which the data comes in and it's a live data which is used for analysis and for dissemination purposes. And so from data, we generate information from which we generate knowledge and which guides action. There are various types of registries. There could be disease-based registries. So we have our National Cancer Registry program. We have the stroke registry. We have the heart failure and the mortality registry. There can be procedure or therapy-based registries and evaluation or quality improvement registries. Registries collect data from multiple points, multiple sources. So there can be patient reported data, there can be clinician reported data from the abstraction from the medical case sheets, the electronic health records, institutional or organizational databases, administrative databases, and yes, death indices, because we would like to look from disease to outcome. So all of these various sources form the strength of a registry, and the data elements that we collect represent a clinical concept of a patient. That means it could be a diagnosis, a clinical visit, a lab value, and use standardized terminology. What kind of data elements do we collect? Identifying information. This is most crucial because we need to do a lot of data cleaning and analysis based on identifying information. Demographic details, exposures and past history, clinical information, and clinical and vital outcomes. Now, I'm giving an example of our cancer registry program, which we run online as well as we run it offline. In an online, to your left arm, the data is entered after a credential is provided to the registry authorized person to enter the data live on the server. And this data is transmitted to us through the web server, and it is all encrypted. It comes to the NCDIR server. Whereas in the offline, which is on the right arm, after the login, the data is entered, it comes into an MS SQL server database, it is exported, and then the file is transferred to us via email also. And so we are encouraging most of our registries to shift from offline to online to provide more secure data transmission. Now, this is a typical workflow pattern of a hospital-based registry. The case and example given is cancer, but it could be many other registries. We start from the left side of the figure, from registration, diagnosis, come to the center where the diagnosis is established, and then the data is abstracted from the clinical records. Now, when data is abstracted, we need identifiers in terms of the name of the patient, the age, the gender, address, phone numbers, name of husband, parents, because we need this in the next step. Where you see the next arrow, blue color, is QC, that is the quality checks. Here we run a range of checks, named range check, consistency check, unlikely check, family checks, and here this identifying information is extremely useful. As you would be aware, a lot of cancer patients move from hospital to hospital seeking treatment. And so if we count every patient, then we would be overcounting the cancer incidence. So we need to be very clear that we are not overcounting and we remove duplicates. So duplicate removal is an extremely important activity in providing accurate estimates of any disease. And then this goes through a series of checks and generation of tables. And all this data which is presented is aggregated data with no identifiers either of the individuals or of the institutions. So comes to what are the uses of a health registry or a data registry. On the left side, you see that into a cancer registry, we get a lot of inputs coming from electronic medical records, hospital diagnostic centers, screening programs, population level data. And the outputs are given in terms of magnitude of the disease, regional variations, gender and age distribution, patterns of cancer care, and this gives rise to a lot of hypotheses. And so we are able to monitor trends in health and disease, give information for allocating resources, and I'm very happy to inform that the entire cancer control program of the country depends heavily on the data of the National Cancer Registry program. So a lot of tertiary cancer care hospitals which are being opened up by the Ministry of Health use this registry data in priority setting in healthcare planning. It is used for improving the quality of healthcare interventions, monitoring health impact assessment, establishing a communication network, ensuring global data on disease surveillance, and obviously it gives rise to a lot of hypotheses for further research. Now, we have been contributing a lot into the biological data storage, access and sharing policy of India developed by the DBT with our experience of handling large data sets. And we are very happy to be part of the National Digital Health Blueprint brought out by the NITI Aayog or the Health Stack, in which you will find the mention of the National Cancer Registry Program as an example, and we contributed in the developmental discussion of this Health Stack. So some of the ethical questions which we are asked by our collaborators are, should hospitals participate in a registry? What approvals are needed to abstract patient data from medical records? Why collect patient identifying information? How to follow up patient for outcomes after discharge, and how to report registry data? So some of these points I have covered in my previous slides, but to list out the ethical issues is about data ownership. Institutions involved in data collection and storage are the custodians of data. The ownership lies with the patient. Policy for data processing, use, disclosure, and data protection, which has been developed by us, has been shared with all the registries, which guides them into this process. In the absence of any disease notification or a public health act, and in the absence of a legal and a regulatory provisions, unlike many of the developed countries, we still rely on some of goodwill gestures by institutions and investigators to be part of the registry. We do take care a lot about patient confidentiality to maintain privacy, and also, as I mentioned, in terms of data storage, data transmission, encryption is done, and we do not share data with any third party without a reasonable reason and putting the due processes of approvals in place. Institutions review boards may approve waivers or alterations in the informed consent in terms of handling the registry data, and look at the applicable regulatory requirements which come up from time to time. The NCDIR, we developed the policy of data processing and disclosure in 2017. This was a consultation held across all our registry points, and this gives a lot of guidance around data collection, data security, as well as data sharing. I would encourage you all to go to our website. You can freely download this policy and go through it. So what we realize is that epidemiology stands in the middle of a lot of good things we do, and it stands as an important tool for a registry, for public health, for surveillance, and for policy development. We have more questions on ethics around this than we have answers, and we thought that this would be a good starting point to initiate these discussions. We may have less to tell you, but we would like to listen more from you in terms of ethical concerns that you face, or there are dilemmas in dealing with such kind of research activities. So the program ahead of you would be that we will take you through the National Ethical Guidelines for Biomedical and Health Research, Dr. Roli Mathur, including the COVID-19 pandemic guidelines. Then the chair, Dr. Vasantha Muthuswamy, would take you through the GCP guidelines, new drugs and clinical trial rules, and the DHR registry. Then Professor N.K. Arora will take you through the ethical issues of epidemiological research, and we would like to have as many question and answer sessions which Dr. Muthuswamy will steer. So with this, I would like to end and thank you for being here with us. Please follow us on our social media accounts on Facebook as well as Twitter to be updated on our activities, and do visit our website. Thank you.
Sir, for an overview of huge network of registries and the importance of ethics in dealing with health informatics and epidemiology. Thank you, sir. Now, going forward, the next session for today is on National Ethical Guidelines for Biomedical and Health Research and National Guidelines during COVID-19 pandemic. To present that, we have with us Dr. Roli Mathur. She is Scientist F and currently heading the Icmr Bioethics Unit, NCDIR, Bengaluru. She is involved in developing ethics policy for biomedical and health research in India. She coordinated the finalization and release of the National Ethical Guidelines for Biomedical and Health Research on Human Participants 2017, along with other guidelines. We welcome you, ma'am, and over to you, ma'am.
Actually, this was planned as an update for the institutions, ethics committees at various institutions that were part of the NCDIR network. But we've had a very overwhelming response in the last few days where we received numerous requests from number of institutions. So this is just to tell you all that there will be more such programs. This was the first one of its kind meant for the NCDIR network of institutions, focusing on the registry program and the epidemiological research involved. So I'm very happy to share with you the National Ethical Guidelines 2017, which many of you would be really aware of already, and the latest guidelines on COVID-19 guidance for ethics committees. So we have been planning a number of activities and we've done a large number of training programs. Of course, we were slow in the last few months because of COVID, but now I think we'll catch up with our trainings. And in the last 2 years, we've done quite a number of trainings covering more than 7,000 participants. So the national guidelines, of course, 2017 guidelines were there, but then in 2019, after the COVID 2019, in April 2020, we brought out this new document, which is actually an add-on. So basically, today what I'll try to do is to cover the main guideline document as well as the COVID guideline document, because the COVID guideline document has to be seen in conjunction with the national guidelines. So the new guideline has some added on information related to review of COVID related research or non-COVID related new research or ongoing research of any nature that was going on, and how to do meetings virtually or in an expedited fashion, how to use electronic informed consent methodology. So there are some suggestions that have come up with the new norm of social distancing. We need to change. The quorum requirements, for example, need to change, because earlier the ethics committee meetings were always in person and attendance was recorded only in physical presence. But now we have moved on to electronic attendance. So there is also emphasis on participatory practices, employing innovative methods and tools in dealing with stigma and psychosocial well-being, violence, preventing infodemic in the new guideline document. So I'll be briefly covering. So we are all aware of the principle of ethics, the principles of autonomy, beneficence, non-maleficence, and justice. And just to highlight the fact that the guidelines of ICMR are applicable for all biomedical and health research as well as socio-behavioral research, which involves not only human participants, but also the biological material and their data sets. These are the 12 sections of the main guideline document. The first 6 are more general in nature. The next 6 are more specific chapters depending on the kind of research you are involved in. So starting from general principles, general ethical issues, there is a section 3 on responsible conduct of research. I have highlighted in red because this is a very important section for all researchers. It tells about how, what are the responsibilities of the researcher in the conduct of research. Then there is a chapter for ethics committees, and this would be very important for all the members of the ethics committees who have joined today on ethical review procedures. There are sections which were earlier there but have been expanded into full sections, that is informed consent and vulnerability. Then the next sections are clinical trials, public health research, socio-behavioral sciences, human genetic testing and research, dealing with biobanks and data sets, and research during humanitarian emergencies and disasters. So these are the ones in red are the new sections that were added in these guidelines. Now, guidelines have given the 12 principles, which is principle of essentiality, which talks about need for research, voluntariness of participation, non-exploitation of people who are involved, the social responsibility to ensure that the research is done in a manner that is beneficial for the society, ensuring privacy and confidential information of participants, minimizing risk done by people who are professionally qualified, competent, trying to see how we can maximize benefits and be responsible for the outcomes. There should be accountability and transparency in all these things. And institutions have a responsibility of providing for making all arrangements that are needed for good conduct of research. And of course, principle of transparency, accountability, and protecting our resources in the conduct of research. Now, this is from the main guideline document, which has explained how risk-benefit assessment could be done. So on one hand, one needs to identify what kind of benefits are there and what kind of risks are there. Are they directed to individual or are they directed to the community or society? And similarly, the risk, whether they are direct or indirect, whether they are physical, whether they are psychological or social risk or economic or legal. So depending on all the listing of benefits and risks, a risk-benefit assessment has to be done by the ethics committee members to see whether this research is justified and should be conducted. And then categorize the risk into various categories, for example, less than minimal or minimal risk or low risk or high risk, and accordingly plan the type of review. So whether the research can be exempt from review, whether it can be expedited for review, or whether it has to go for a full board review, a full ethics committee meeting. So it will depend on the kind of risk involved. Then there is a description about how to take care of the private information for participants and confidentiality of these individuals. And especially it becomes important in the arena of COVID when we talk about, because this is highly sensitive. There is a scope for stigmatization, discrimination, violence. So the way the information is handled has to be seen by the ethics committee, reviewed by it, and taken with care. What about the confidentiality of data when it is going to be published? There is the need for relevant disclosures, which are mandatory disclosures to public health authority. So you have to, on one hand, declare this information to public health authorities, but how this information is declared, that it is not in a way that it leads to discrimination of an individual. It's very tricky, especially, but all these things have to be looked at with due care when we are reviewing research. The storage of samples or biological material is another important aspect that has to be seen in view of the COVID. Now, how these samples are going to be stored, how they are going to be transferred between lab to lab for testing, who will be the custodian of these samples or data. When it is epidemiological research or some field studies and there's some sample collection or then it has to be seen how that transfer is to be done. Then payment for participation, ethics committees have to review and approve the payments that are involved, and also to make sure that these don't turn up to be undue inducement. These could be in terms of reimbursement or inconvenience. So one has to, this is very important thing that ethics committee has to ask for, and also make sure that in case there is a harm from injury, some kind of compensation, a mechanism is in place for covering for compensation for research related injury. Now, whether it is through insurance mechanism, whether it is through the research grant, when investigators have taken a research grant for that research, that budget should be built into the research funding, or institution charges overheads under which such things can be covered. So corpus in funding can be created in the institution. So ethics committee has to really make sure that it's not only clinical trials. I know a lot of ethics committee will look at it into more closely, but then also for biomedical and health research, if there is a related research related harm, that people need to be provided with medical management and compensation. Then conflict of interest are the other difficult situations which is often not taken very seriously or not very well understood. These are set of conditions where your judgment could be unduly influenced due to a secondary interest. It could be at the level of the institution, which means that the institutional authorities could put pressure on the ethics committee to approve a study, for example, or the conflict of interest may be in with the researchers, but they need to declare those conflicts of interest to the ethics committee. Sometimes the ethics committee themselves, the members themselves have conflicts of interest, which could be academic interest or it could be financial interest. The important thing is to recognize and to declare these interests so that they can be appropriately managed. Then community engagement and distributive justice becomes very important in the COVID scenario, because the way the research design is, communities should not be selected in a manner that they are going to bear the burden, but they are not going to get the benefits that come out of the research. Or people who are disadvantaged or disabled, or such people who are economically or socially disadvantaged should not be used, for the benefit of others. And communities need to be meaningfully engaged, which means they have to be engaged while you prepare your study, building up the study. Right from that time, they need to be engaged. And many ethics committees, good ethics committees, would invite members of the community during the meeting in order to give their comments and to take their feedback in designing these research studies to make them more culturally appropriate, so that the outcomes can also be transferred back to the communities who participate in research. Therefore, it's very important, especially now, to engage with the communities to improve trust, to educate them about COVID-19, prevent infodemic, prevent spread of wrong information, and involve them in planning. So these are some of the things that are there in the guidelines. The section on responsible conduct of research that I mentioned talks about scientists as a responsible member. It talks about what kind of policies and SOPs need to be in place, how conflict of interest can be managed, how data is acquired, managed, shared, owned, and how reporting has to be done, authorship requirements, how to handle misconduct, and how to do collaborative research. Actually, half an hour is not sufficient to deal with the whole guidelines, so I am going a little fast, but then I urge all members who are attending to go through this section. The section on ethics committee tells some ethics committees to be independent in their decision making, to work without any pressure, to be competent. This is also an important factor. You have to be competent, you have to be time bound, which means you have to calculate your turnaround time. How much time was taken from the day the proposal was submitted to the day of its approval. So this is the turnaround time, and that should be reduced by a good ethics committee. So they have to make sure that the rights, welfare, safety of participants are well protected by carrying out a good, robust scientific review as well as an ethics review. A study which is not scientific will not have an ethics value actually. And they have to conduct an initial review as well as continuing review and monitoring of every research that is approved. And decisions regarding ongoing studies also need to be taken. Re-review may be required in the view of the amendments that may be required with the changed circumstances due to COVID. And so therefore COVID, new research and non-COVID research. The important point I wanted to highlight was that sometimes ethics committees are, they don't connect well with the researchers, and that really is not helpful. The ethics committee have to handhold, support the researchers. If they do not like a project or they have some queries, they must help the researchers make the project ethically acceptable, give out concrete suggestions for improvement of the study. Whenever they want to reject a study, it should be given with reasons. So it's important for ethics committees and researchers to connect with each other and bridge that gap. Otherwise, researchers feel that ethics committees like to reject the proposals, or they are too critical of my research and what to do, and such things keep coming up. And ethics committees therefore also need to be abreast with the national as well as international requirement. The latest what is happening around, they should keep themselves updated and implement the best practices. So, and then of course research has to be reviewed before it has to be initiated. So now in the new guidelines, what is discussed is about reducing the timelines, the time frame for review, having video meetings like this is of course a webinar platform, but then having a video face-to-face meetings. And our experience of the Central Ethics Committee has been excellent, where we've had members and we have been able to have a turnaround time of only up to 72 hours for most of our studies that were submitted to Ethics Committee for review. Have short agendas rather than having long agendas, have small agendas. Have more frequent meetings of shorter duration, because more than 2 to 3 hours becomes very daunting in an online meeting. So these are some changes that have to be implemented by the ethics committees. Then while they review, make sure that there is a prevention of stigma and there is a balance between privacy and mandatory disclosures, procedures for oral and electronic methods of consent, and then of course ethics committees have to have standard operating procedures and which need to be implemented. They just don't need to be in theory. A lot of ethics committees have just SOPs which are in theory but not put in practice. So these have to be put in practice. You know, sorry, what happened? Oh, sorry. Yeah, so the ethics review procedure, this is ethics committee needs to have budget, which means the institutional responsibility to provide budget, staff, protected time for member secretary, members to have due qualification, affiliation, roles and responsibilities which have been defined in the guidelines, head of the institutions or authorities not to be part of the ECs so that there is no undue pressure on the ethics committees and they can act independently. There are special situations where one ethics committees, there could be not just one, but an institution can have more than one ethics committees, or they can use other institutional ethics committee for the review. Multi-center research can be done through a common review. Independent ethics committees are there. Subcommittees can be appointed. So these are some suggestions that are there in the main guideline, but in the new guidelines, some additional suggestions are there that, you know, now due to this in the pandemic situation, it will be useful to have alternate members, because when you're trying to fix up a meeting, let's say within 24 hours of receiving a proposal, a member may not be available and the timeline or notice is too short. So if you have a set of alternate members with decision-making powers who are also appointed, it will make your review faster. You could have panel of experts who could be invited to give opinion, scientific opinion, special invitees, patient representative groups or communities for who do not have a role in decision making, but they can give their comments. And of course, members who are ethics committee have to be willing to devote their time. They are committed to be, this is of course a thankless job as most of us understand, but then we have to be committed for this. Of course, ethics committee needs to be multidisciplinary and have age, gender appropriate representation, non-affiliated members, etc. And ethics committee needs training. Members need training on about what is research. They must understand methodology, principles, designs, conflict of interest, SOPs, review procedures. So these are some of the things every ethics committee should know about. Yeah. So of course, each member of the ethics committee has a responsibility. The legal expert, social scientists, clinicians, subject experts, every member has a responsibility that has been well described in the guidelines. Common review of multi-center research is a new thing that you all can try. Some of the research where you have a common protocol can be reviewed jointly by one designated ethics committee. We have tried to make it work at our end, and many of you can also try in your own institutions. And also there are special suggestions that are about subcommittees and others. Now, ethics committee, of course, reviews science and ethics. It has to look at social value, etc., design, benefit, risk, payments, all these things. Now, important thing now is that when a member secretary gets a research, they need to categorize the research, whether it is falling into an exempt category, whether it is falling into expedited review, whether it is a full committee review. So that is the first step. And then plan a meeting, scheduled or unscheduled. It should be planned to fast track the review process. And encourage that the researchers are using alternative designs, and confidential information exchange through IT has challenges that ethics committee has to see how the information is going to be transferred between sites, or how study is going to collect the information. Then sometimes studies may use GPS or IP address tracking. So these have to be reviewed on a case-to-case basis, and we need to learn from your experiences as to how you have faced such things, and review whether it can be done by other ethics committee. If an ethics committee is not available, that provision has also been created in the new guideline, and it's important to do timely review, monitoring, and to see where oral consent or electronic consent can be permitted, and how to make sure that this consent is robust, how to make sure it is good quality, how to digitally record your meeting attendance and minutes. So these are some of the new changes that may be required in the ethics committee functioning. my slides get stuck for some reason. Okay, so informed consent process is the other important thing that the ethics committee review. We know these are the elements of the informed consent form and ethics committee, that is as per the guidelines, but then there are some additional things that also ethics committees need to review: the alternative procedures, stigmatization issue, insurance, future use of samples or data, benefit sharing, publication aspects, and so on. And now with the new guideline, we have the provisions of electronic consent were already there in the 17 guidelines, but now more explicitly they have been given that alternate procedures can be used using technology, text, graphics, audio, video, websites, platforms. You can have apps, you can have WhatsApp. Or now important thing is how this electronic consent is going to be documented, whether it is going to be audio recorded, video recorded, or any other through email or digital signatures. So these are the various new things that we all need to adapt to. So there may be challenges because in conducting a research due to isolation, quarantine, COVID ward and all these things. So we must, as ethics committee members, understand that, these may be challenging because of the decisional capacity may be low due to illness. So how we must let the consenting be done appropriately. And also to make sure that a patient is able to distinguish between relief, care, and research. Okay, so the ethics committee needs to look at translations, test of understanding. To deal with people who are differently able, there should be time for discussion, decision, no intimidation, impartial witness, documentation, all these things. Now there are challenges. A lot of people ask, how will we have an impartial witness, how to have a legally authorized representative from a patient who is in isolation. So these are all tricky things, and that is why it has to be reviewed on a case-to-case basis by the ethics committee to see what can be allowed. We need to be flexible. We need to make sure that research has to go on. On one hand, we have to allow research to happen. On the other hand, we have to make sure that the rights of the participants are not violated. So we have to review this more carefully to make useful suggestions to the researchers, to discuss with them how best they can do it in the change scenario. So one second. Okay, yeah. Now, waiver of consent is something which often people do ask, that where we can allow waiver. Now, waiver is generally recommended for research where it cannot be practicably carried out or whether it is not scientifically justified. It could be for retrospective sample analysis or de-identified anonymized data, for public health programs, surveillance programs, program evaluation, data which is in public domain, waiver of consent. So registry program is also one of the examples where waiver of consent could be sought if data is going to be used in a particular format, taking care of the identifying information of the participants. Or when research is being done in emergency situation where participant is not in a position to consent, and in such places it could be done later with EC approval. So these are the situations. Now, dealing with vulnerability is very important. So many a times we find that ethics committee or researchers actually find it very easy to just exclude the vulnerable groups. They say we will exclude. Now, for example, vaccine trials for COVID are coming up, and it will be very easy to just exclude the children and pregnant women and people in reproductive age groups. You just exclude. But that's not the idea, because if you exclude everybody, then the benefits that come out of this research, any kind of research actually, will not be applied to them. Therefore, ethics committee has to make sure that the vulnerable people are included in the research wherever possible. But there are additional safeguards, there are procedures built into the study to make sure that these people benefit and they are not, the researchers have to take the responsibility of overprotecting them. So all this has to be seen with due care rather than just exclusion. So clinical trial, there's a whole chapter, and this is not a topic for discussion today, but Dr. Muthuswamy will be covering up the new drugs clinical trial rules. But then other than regulatory trials, the Icmr guidelines have discussed the other non-regulatory academic clinical trials and what are the requirements that need to be followed are given in detail in this section. Then there are two sections, one on public health research and other on socio-behavioral research. These will be very useful for the ethics committees to go through, because this is one area which is very tricky, because there is a very thin line of distinguishing between public health practice and public health research. Often data collected for public health programs is also used for research, and therefore this area is happens to be a gray area. And this includes various types of research, implementation research, program evaluation studies, surveillance programs, screening programs, surveys, observational studies, registries. And Dr. Arora is here, and we thank him for joining today, because he will be highlighting more details about such designs or qualitative studies that are done, and how communities need to be engaged, how we have to make sure here that the benefits are not sometimes directly to an individual, but they often apply to public health or to people or communities or populations. But still, we have to see that vulnerabilities of communities are not exploited. There's an in-depth need for reflection on these, and aim at public health good through societal benefit. So these are two important sections. And there is one full section on human genetic testing and research. It talks about all the emerging genetic technologies related to, for example, CRISPR is in news nowadays, or other, prenatal diagnostics or genetic testing, counseling, consanguinity issues, a lot of socio-ethical legal issues that need. So it may be useful for you all to have a look. Then this is another very important section from the ethics committee point of view, as well as researchers, and that is on biobanking and data sets, where when you look at an informed consent, how do you decide what kind of consent should be there? And now that will depend on what kind of sample or data are we talking about? Is it completely anonymous, or is it anonymized, or has linked information, or is it coded information? Or is it totally identified sample or data? So depending on the type of sample or data we are talking about, the informed consent has to be planned. So it could be, for example, if it's anonymous, you could think of waiver of consent. Or if it is anonymized, then you could think of, because if there is a plan for later, and the next step after the research is over to anonymize and use it for future research, then in that case you could think of having provisions for blanket or broad consent. Or it could be tiered consent, stepwise. So there is an initial consent for screening and then for the main study. So there are different types of consent processes that have been discussed, and this is an important section for all, whether it is researchers or ethics committees. Wherever there is transfer of biological material or data involved, there has to be appropriate memorandum of understanding or an MTA that has to be there. Then the 12th and the final section of the guidelines of Icmr has spoken about humanitarian emergencies and disaster. This section was prepared when we had no such idea that there would be some day where we would be sitting like this, like today. But this has suggested a framework for preemptive preparation. It has suggested the ethics committees to have expedited reviews and scheduled meetings through teleconference meetings, and to think about informed consent, giving waiver of consent, but making sure there is equitable distribution of benefits and risks, preventing stigmatization and engaging in a community sensitive manner, and also speaks about new interventions which could be unregistered experimental interventions. So this is one section that an ethics committee should look at it, and the role in the new guideline, the role of agencies, sponsors and governance of research has been explained. That on one hand, the need is to fast track research, set up community consultations, facilitate post-trial access, disseminating useful information, curbing false information, expeditious review, expert group consultations, ensuring safety. So there's a lot more to do, a lot more things to do, because we would not like to compromise on the quality when we are talking about. We have to fast track, but we cannot compromise on quality. So while the new guidelines, this was the guideline that was prepared, the COVID guideline, along with this, what was also prepared was the SOPs, because many ethics committees found that they did not have SOPs for expedited review or emergency review for holding meetings in emergency situation. So a draft SOP has been prepared, posted on our website, and it's also available at the end of this document. And you all are requested to have develop your own SOP in your own ethics committee for emergency review. You could use it as a format and modify it as per your own requirements. Then the other useful thing is the common form for ethics committee review. These are common forms available on NCDIR or Icmr Bioethics webpage. These are forms that were prepared 2 years ago and in collaboration with THSTI. These are very useful tool for ethics committee. So when a protocol is being submitted to the ethics committee, there are very useful checklists and it asks the right kind of questions so that it makes the submission complete and it makes it easier for ethics committee to complete such review process. Again, these forms are formats. As you see the logo space, we have left blank. Any institution can download it, adopt it, put their own names, logos, everything, modify it. It's available in Word, PDF, and use it. So we don't have not only initial review forms, but there are forms for expedited review, forms for amendments, reporting essays, protocol deviations, CV of investigators. So these are very useful, and if you would use them, I'm sure your work will be much easier. And we have implemented and found them to be useful. But of course, we welcome your feedback. If there are suggestions, we really welcome that from you. And of course, there is a handbook that was released last year. This is a brief document. It's good for students or researchers who are, they want a quick summary because they don't want to go through the main guideline. So this highlights the important this thing. Please write to us if you would like a complimentary copy of the handbook. It is a brief document, but it's very handy. Then Icmr had prepared a right policy last year. This is meant for Icmr network of institutions. It talks about dealing with misconduct and authorship issues and framework for making sure, ethical and responsible conduct of research. However, any institution can adopt and, use it as per their own requirement. This is just a suggestion for a framework. And then the next slide. Getting stuck again. Yeah. So on our website, you would find that there are a lot of tools that we have made available, not only national tools, but also international guidelines. There's a lot of reading material available. Latest updates are posted. So I urge members of ethics committee to please visit our website for more information. Now, what kind of reorganization can be done by you all during the pandemic is that you need to adopt responses, which is innovative digital platforms, technology, adaptive study designs, have virtual meetings which are short, frequent, shorter agendas, electronic recording, ongoing research. Please allow that to continue and not suffer by implementing needful changes that are needed. Like, for example, follow-up visits could be changed from physical visits to telephonic visits. And there are steps that are needed to fast-track review. New committee, alternate members can be appointed, independent experts or subject experts can be invited, ensure availability despite short notice, and turnaround time can be duly reduced. Platform for registration of all COVID-19 research, CTRI platform can be used. So while ethics committees are encouraged to review rapidly, no short courses or compromises on quality are expected. This is just a glimpse of the downloads that have happened for the new guidelines. We have more than 30 countries who have downloaded our document, and also, as you see from across the country, the documents have been widely downloaded and I hope they are used. And I feel happy to share with you that Icmr guidelines are recognized as one of the only guidelines from any developing country which is listed on the OHRP website in the US to be offering equivalent protection other than the US rules and the Canadian. I'm not saying the US rules are the best or anything, but I'm just trying to say that our guidelines happen to be the only other guidelines other than US and Canadian and GCP guidelines. So with that, I'd like to thank you all, and we'll have the question and answer discussion in the end of the talks. So please keep your questions, please keep posting them in the chat, and we'll be happy to take them up. So thank you all very much for patiently listening, and I hand it over to you, Shilpi. Thank you very much. Yeah.
Thank you so much for sharing the details of the ethical guidelines with us. Moving forward, the next session for today is on GCP guidelines, new drugs and clinical trial rules, and DHR registry. To present this, it's indeed a great pleasure to welcome Dr. Vasantha Muthuswamy ma'am, the chairperson for today's program. I am profusely elated as I do so, and words fall short as I introduce ma'am today. She retired as Senior Deputy Director General, Scientist G from Indian Council of Medical Research and is well recognized in bringing out the ICMR ethical guidelines in 2000 and the revised versions in 2006 and 2017 along with the other guidelines. She is presently a president of Forum for Ethics Review Committees in India, FERCI, and secretary for Forum for Ethical Review Committees in the Asian and Western Pacific region, that is FERCAP. She has been a member of ethics committee related committees at WHO TDR and United Nations Program on HIV/AIDS, UNESCO, etc. and is also currently the chairperson of Central Ethics Committee of Human Research, CECHR, which is proactively involved in the review of COVID-19 and non-COVID-19 related research for ICMR and its network of institutions. She has colossal contributions and is an inspiration for many all across the country. Thank you so much, ma'am, for gracing the program with your presence. We welcome you, ma'am, and over to you, ma'am.
Hey, good morning to everybody. I am so happy to see that so many people have joined this program to listen to these presentations. And for a change, today I am not going to speak much about the ethics part of the whole thing. This is whenever we are talking about the ethics committee members or the investigators, we always say that the people have to be GCP trained. So people do wonder that what is this GCP, what is the GCP training? And if you really go to the details now, you'll see that it's not much different from what we are talking in the area of bioethics. So today I'm going to speak to you about the GCP guidelines, the new drug and clinical trial rules, which are connected. And then, of course, in the process, we'll also talk about the ethics committee registration and accreditation, which are the latest developments in the last couple of years in this country. Now, when we are looking at the laws and the guidelines, we'll have to understand what do we mean by a law and what do we mean by a guideline. A law is something which is within a walled area. We are there within a walled area. We are safe if we are within this boundary. If you cross the boundary, then you are penalized. You can be penalized, and this penalization, it's already mentioned in the law. It fixes the punishments. It talks about your responsibilities. It talks about your accountability. And when we are talking of guidelines, so whether it's a GCP guideline or an ICMR guidelines, a guideline is also the code, and it's a roadmap which sets the standards so that one does not get lost in the whole process. So we know that what is to be done and what is the way we'll have to take in our whole procedure, in our journey for doing research or in whatever activity. The guideline doesn't talk about any punishment as such. So it's up to us to follow the guidelines. But then, of course, if you have a breach of standards and if something goes wrong, there are ways in which the punishments can be given to the people, and that's where the law comes in. So the guidelines and the law go hand in hand, and we have to understand always when we see what are the guidelines to be followed for doing research, we have to understand that what are the other allowable laws which are there in this country, which will keep a control of people not deviating from the guidelines, not doing anything which is wrong. Always you do what is right. Now here we are going to talk about the GCP guidelines. GCP is what is good clinical practice. Now when we are talking about research and about the research guidelines, why are we have to talk about the good practice guidelines is a big question mark. But then actually it's a misnomer. GCP is a misnomer. It is not about the clinical practice or about the clinical ethics. It is regarding the research. It should have been called a good clinical research practice, but when it is formed at that point of time, it was termed the GCP and the name continues till now, but actually it is a GCRP. So it's an international ethical and scientific quality standard. It's for designing, conducting, recording, and reporting trials. So the word which is used in GCP is trial. That means, as you can understand, this is mainly for conducting clinical trials that involve the human participation of human subjects. Now the word subjects, you heard from Dr. Roli that the ICMR guideline is called Guidelines for Research and Human Participants. That's a word which we changed in the process of developing a guideline from 2000 onwards, that we felt the word subject is denigrating somebody to a lower status. We should call them participants, because if there is no research participant, there is no research. They are the main, the central role of any research. But however, in the international scenario, the word subject is still being used, although there are changes have started happening in many of the international programs. So the ICA-GCP is an international committee on harmonization, which started in 1996, and I'll tell you what it is, which came out with this concept of GCP. And then also the WHO has brought out a handbook of this good clinical practice in 2005. And here it says that GCP is a process that incorporates established ethical and scientific quality standards for design, conduct, recording and reporting of clinical research involving the participation of human subjects. So you can see that there is a little change of terminology. The ICA-GCP says reporting trials. The WHO has already made it a clinical research. So it can be any research involving human beings. Yes, it also should come under the guidelines of GCP. So the concept of a good clinical practice, which came out in 96, and recently, of course, as you see that all the national international guidelines are getting updated constantly. This is also updated in 2016. So it's mainly an international scientific and ethical quality standard for doing research. So it talks about whether it is designing the study, conducting the study, recording the information, how do you collect the data, and finally, how do you report writing. So everything is encompassed in this guideline. But the main purposes are two. One is the patient safety. So how do you protect the rights and welfare of the participants? The second is the credibility of the data to ensure a credible data. So you can see that as far as today's program is concerned, you just heard from Dr. Roli about the ethical guidelines, that is for the patient safety and the rights of participants. You heard from Dr. Prashant Mathur about the registries, which is collecting the data, so the credibility of data. So this is a very good program that we really want to talk about GCP. These are the two things. So you're not going away from ethics. Ethics is part of the GCP. In addition to that, it also talks about the data credibility of the data and the value of the data. So these are the two basic components of a GCP guideline. So if you look at the ICA-GCP history, it is very interesting. When it started, the International Committee of Harmonization, the whole thing started because in that part of time, that is in the 90s, every country had its own regulatory procedures, and the pharmaceutical company found it very difficult to reach a global market. Every country has to have its own rules and regulations, and they were finding it very difficult because the different kinds of data has to be submitted for different countries or different regulatory bodies. So the problem was there for marketing new drugs internationally. It was time consuming, it was very expensive, very costly. A lot of delays were there, and so it took time for the safe and efficacious new drugs to be marketed. So the international organizations decided that we have to harmonize the regulations and guidelines so that all over the world, everybody follows the same procedure, so that if one organization is accepting it, it's easy for the industries to submit it to the other agencies, maybe with mild changes may be needed, otherwise the major there are no changes. And this is how the tool started. You can see the 6 sponsors from each region, whether it's eastern side is Japan, United States, and the western side, the entire Europe. In addition to that, a lot of pharmaceutical companies, health authorities, WHO, Canada, the Australia, everybody joined in this. That's why it's called it started as International Conference on Harmonization, and it became an International Committee on Harmonization. And they came out with these guidelines, and the guideline has mainly 4 categories. It talks about quality, which is about the chemical and pharmaceutical quality assurance. It talks about safety. It also includes in vitro and in vivo preclinical tests in animals. When it comes to the efficacy, of course, this talks about the clinical studies in human of all these products. And then, of course, it also have other multidisciplinary component of it regarding terminologies, different standards. Under the efficacy codes comes the GCP guideline. It is called the E6. Generally, it is said that you have to follow E6, which is the GCP guideline. The first one, which came out in 1996, called the R1, and the second one, which has come recently in 2016, it's called the R2. Of course, it has got the other things about the efficacy codes. We'll not go into the details now. The ICA-GCP 96, it sets up the standards for clinical trials. It has given the framework as to how to conduct a trial, in the sense how to design a study, how to conduct it, how to do the recording, and how to do the reporting, with the one figure which I showed in the beginning. So the principles, if you look at ICA-GCP principles, there are 13 principles. That is how to conduct trials according to the GCP principles. How do you weigh the risk benefit? How do you protect the subjects? What kind of information which is necessary to justify a trial? So the scientific background. How to write a sound protocol? What do you mean by IRB, IEC approvals? Qualified physicians have to be there. Qualified supporting staff has to be there. How do you obtain the different consent and whose responsibility it is? How do you record information? How will you protect confidentiality? How will you handle the investigational products and implement quality systems? So I'm not going into the details of each one of them. Sometimes in the GCP workshops, we'll have to give a detail, but now within the short time frame, you have to just understand that these are the basic principles. So you can see that many of the things are related to the ethical principles. Of course, in addition to that, it also talks about the products and the recording. Indian GCP came out in 2001 from the CDSCO, the Controller's Office, and that follows Icmr ethical guidelines of 2000. And that's the reason the Indian GCP still uses the word subjects. I understand it's going to be revised very soon and released. Probably it was to be released early this year. There is a delay because of the COVID situation. Once it comes out, I am sure that that will now follow the 2017 guidelines. And so there will be a lot of harmonization between the Indian GCP and the Icmr guideline. The GCP, when we talk about, they are giving it gives in details about the responsibilities of the different stakeholders. Of course, the patients, as said, are the central part. It can be patient or it can be healthy volunteers also in some of the trials. So it gives the responsibility of the sponsors. It gives the responsibility of the investigator, site staff, and in between, there are two more agencies that are involved, the CROs, the contract research organizations sometimes, which actually help in conducting the trial, and the monitors who come for monitoring the trials. And then, of course, you can see the institutional ethics committees, which give the approvals, and then, of course, the regulatory authorities. So these are all the various stakeholders involved in the clinical trials or clinical research. And so it gives a responsibility of each one of them. So investigators have to, their responsibilities should have the qualification, adequate resources. They are concerned with the medical care of trial subjects till the end. They have to communicate with the IECs. They have to comply with the protocol. They should not make any changes. And then if any changes to be made, they have to report. And they have to take care of the investigational product storage as per the instructions given by the sponsors. Like taking informed consent is the investigator's responsibility. So they have to plan before the trial. When do they do the screening? How do they take the consent? Whether it's a written consent and what are the other procedures, and as per the prescribed forms, and then how the translations are to be done, if at all any reconsenting has to be done. So everything is the responsibility of the main investigators. They may obligate this work to somebody else, but then the responsibility always lies with the principal investigators, and they have to be, it is their responsibility as to how to get all these procedures done properly. They are also responsible for doing a very accurate, complete, legible recording of all the information as per this in the CRF, keep them. So recording, the reporting, and also the safety reporting of adverse events. And they have to follow the timelines which are prescribed, and they have to always assess the relatedness. There are many questions in the chat box which have come on SAE reporting and the relatedness issues. This is something very important. Maybe we can answer during the question answer session about it. The ethics committees have a responsibility before giving approval. They have to review properly, see that all the issues are there, all the records are properly being maintained, and everything is properly submitted before giving approval. During the trial also, they have that to see any amendments are being made. Is there any protocol deviation? How do they assess progress? Regular monitoring has to be done. The ethics committee also has to ensure record keeping of every activity and changes which they are suggesting. Of course, serious adverse event monitoring. After the trials are over, they have to review the study report, see what is the kind of post-trial management is needed, and post-trial access to the product if there is wherever it is necessary. They have to also oversee the ethical publishing of the information. So any publication which happens in a clinical research or a clinical trial has to be reported to the ethics committee, which is not done in many cases. It has to be done. Ethics committees, they are giving approval. They have a right to know what is the information which is coming out of these studies. And of course, they have to ensure record keeping and the archiving. The sponsor, of course, has the major responsibility. They have to choose the right contract research organization, if at all it's needed, other than the investigators. Trial design is made by them, the trial management they are responsible, quality control, quality assurance, data handling, data record keeping. And then, of course, they have to have what is called an independent data monitoring committee, which is the data safety monitoring board. So all these things are sponsors' responsibility. Sponsors also have to select the right investigator. If any compensation is when Dr. Roli talked about compensation to research-related injury, any insurance has to be taken. Even whether investigators have to be protected, sometimes even the ethics committee has to be protected. The insurance has to be taken up by the sponsors. All the SAE reporting, compiling them, submitting it to the regulatory authority, seeing what action has to be done through the DSMB, recommendations and the SAE, the IEC recommendation, all these have to be continuously monitored by the sponsors. And then, of course, they have to confirm every time the proper review is done by the IEC. The IEC has the proper quorum to give review. Because if the IEC's review is not proper, it is accepted, and later on, if the sponsors were finding it very difficult, sometimes all the data collected have to be cancelled if the ethics committee review was improper in the beginning. So sponsor has to very clearly see at every step everything is being done properly. So CRO's responsibilities, of course, one knows that they are given the responsibility to actually do the clinical trial, are directly involved with the principal investigators. They are involved in subject recruitment, enrollment tracking, accurate specimen collections, family education before the informed consent process, administration of study medications, advising the investigators about it, the data collection, data management, seeing whether the CRFs are completed, all other documents. These are responsibilities of the CROs. They are also given responsibilities of the monitors. The sponsors, when they designate a sponsor, the monitor, they have certain responsibility to oversee the progress of a clinical trial, whether everything is followed according to the protocol, according to the SOPs, according to the GCP requirements, and according to the regulatory requirements. They have to visit the sites regularly, answer questions from the staff, hold regular staff meetings. They have to give back to the site staff as well as to the sponsors. There are also other monitors nowadays. Earlier, there used to be only the sponsor-induced, the designated monitors. Now we have regulators can send their monitors. Ethics committees can do the site monitoring. So data safety monitoring board is also appointed by the sponsors. Every individual ethics institutions can also have their own data safety monitoring committees. So monitoring is done now by multiple agencies, and we have to see there is a harmonization. There are no confusions which are happening with multiple monitors. So we have to see a proper, the system is put in position. I said that it's been recently amended, the GCP 2016, but only addition which they have made is regarding validation of the computerized software. Now that online data collection is being made and the data management is being done, the new GCP guideline mainly talks about the details of monitoring plan, validation of computerized software. So they call this principle of GCP S2, it comes under the 2.10. They are talking about adequate resources and the quality management. These are the things which have been given more importance at the current moment in the new revision. What is necessary is this: we have to keep pace with the scale and complexity of the clinical trials which are happening. A lot of new technologies we are used, so appropriate use of the new technologies, and we have to also look at the risk-based quality management approach. So these are all is what is added to the new updated guidelines. Now, as I said, that if these are all going to be for a clinical trials, we have to understand what are clinical trials. There are many questions about registration of the ethics committees which will come in the question and answer session. So if you see the definition of a clinical trial, it's any research or study which is prospectively assigns a human participants, a group of humans, to one or more health-related interventions to evaluate the effect of health outcomes. So the clinical trial is not just product-oriented, it can be others also. That's why we can say it's a clinical research. But then there is a distinction is being made now. Even in the ICMR guideline, we say clinical trials which are regulatory in nature are covered by the CDSCO, and the ICMR guideline is other for the non-regulatory clinical trials. So what are the regulatory ones? Are the new drugs, vaccines, the biosimilars, biologics, diagnostic agents, devices, phytopharmaceuticals, radiopharmaceutical, which are all mentioned in the new drug and clinical trial rules 2019, for which we need the CDSCO approval, the requirements as per Drugs and Cosmetics Act. All these are considered as the regulatory clinical trials. But all other interventions which are non-regulatory or the academic trials, I'll give you explain the academic trial a little later. The public health interventions, that's all the epidemiological studies, the socio-behavioral interventions, use of new technologies, which are not actually product related, other technologies, techniques or interventions involving even traditional systems of medicine, which is not covered under the CDSCO in a bigger sense, although some of them, the phytopharmaceuticals are considered, not as such the traditional system medicines. Now, all these are considered as non-regulatory clinical trials, and they are governed under the ICMR National Ethical Guidelines, which you just heard. So we have this two clear distinction of clinical trials at the moment. That's the reason we have to know about the ICMR guidelines thoroughly, as well as we have to know about the new rules thoroughly, so that we know that where the distinction comes in and where the merger comes in, where the difference is there. Of course, as far as regulation in this country, We have a well-defined drug regulatory system. All of us know about the CDSCO and the Drug Controller General of India, which comes under the Ministry of Health and Family Welfare. But then there are also other regulatory systems as far as the drugs are concerned. We have Ministry of Chemicals and Fertilizers, which are concerned in the Pharmaceutical Department of Pharmaceutical. We have the Ministry of Commerce, which talks about the patents, compulsory licensing. And we have the Ministry of Science and Technology, DST, DBT, and CSIR labs. They are involved in the different ways. And the most important is the Ministry of Environment and the DBT, which are regulating the biotechnology products under the Environmental Protection Act 1986. So we have the RCGM under the Department of Biotechnology and the GESC, Genetic Engineering Approval Committee under the Ministry of Environment, which look into the biotech products. So we have to understand what are the different regulatory system which we will have to look into when we are doing research. So coming to the new drug rules, this comes under the Drugs and Cosmetics Act of 1940, under which we had the Drugs and Cosmetic Rules 1945, which we have been following till date. Most recent times, we have been always talking about Schedule Y for clinical trials, which was released in 2005. We also have Drugs and Magic Remedies Act, Objection Advertisement Act of 1954, which is very important when you look into all kinds of stem cell research and new therapies which are going on without proper approvals. But the most important is the new Drugs and Clinical Trial Rules 2019, which is currently controlling all the clinical trials in the country, and everybody has to be very thorough about it. And but what is the difference? We talk about acts and rules. We have to understand what is act and what is rules. What is regulated under the act is the manufacture of product, the import, sale, and distribution. This comes under the act. But what we are all concerned is more under the rules. The new drugs, the clinical trials, even the exports, these are all come under the rules. So this is a distinction between the acts and the rules. So as I said, the recent rule which has come, which is called the New Drugs and Clinical Trial Rules 2019, which released on March 19th. And according to this, what is important is that Schedule Y is no more applicable. So all the amendments which are coming in the 2013, we have a lot of amendments in the Drugs and Cosmetics Act. All those amendments, including the 2005 Schedule Y, no more are applicable. Now we will have to only follow what is the next one. The fourth is the New Drugs and Clinical Trial Rules, which we say NDCT 2019. What does it say? This document has 264 pages, of course, half in Hindi, half in English. It has 13 chapters stating 107 rules of different types. There are 8 schedules and there are 27 forms in the 8th schedule. It gives about the prerequisites and conduct of clinical trials and about different types of trials, bioavailability, bioequivalence, everything. Easy registration. It talks about Icmr guidelines notified for the first time. We have been trying to do this from 2000 onwards. But then finally in the 2019 new drug clinical trial rules, Icmr guideline is included. So it has become notified now, it has become a law of the land. For all research, whether it is not even non-regulatory, all non-regulatory studies have to be following the Icmr guideline. Now it has given a details about this new rules, gives detail about post-trial access, about the composition about the composition of ethics committees and the various new definition introduced. Most important is the definition of a orphan drug. So if any disease occurs in less than 5 lakh people in the country, it's called the treatment which is available needed for them is called orphan drug. So here they very clearly defined what is a new drug. So all the clinical trial which is going on in the country is not under the new drug. A new drug is specific. Of course, the definition changed from what it was earlier. Now the definition is if it is a drug which is not approved for marketing as a drug in any country, then it becomes a new drug. There are also other, they have given much detail about the other drugs. So which are all the new drug is all active pharmaceutical ingredient, phytopharmaceutical new drugs, anything which is already approved. But if you have a new claim for indication, route of administration, dosage and dosage form, any fixed dose combination with any change in the, again, route of administration dosage, if it's a novel sustained drug delivery system or any vaccine or any recombinant DNA product, any of the monoclonal antibodies, stem cell derived product, gene products, okay, xenografts, all these are now considered as a new drug. And what is important is that the 4 and 5 are considered new drug forever. As far as the others are concerned, they are concerned 1, 2, 3, they are concerned as new drugs only for a period of 4 years. So one has to be very clear about it. So all the new technologies are considered new drugs as long as they will be accepted as a standard treatment. Now, what is important here is for everybody. I just said in the new drug definition, as you can see in the second point 2, a drug approved for certain claims and proposed to be marketed with modified and new claims, including indication, route of administration, dosage form, is a new drug. But at the same time, if the same thing is being done for an academic purposes only and not for marketing purposes, this is now being coined as academic clinical trial by the drug regulatory authorities in this country. So the results of such a trial are used only for academic research purposes, not for marketing purposes. Then it need not go to the drug controller for approval. The institutional ethics committees have the right to give the approval. However, if there is an overlap in the nature of the trial, if the ethics committees are doubtful whether it needs a regulatory approval, they can inform the central licensing authority, that's the CDSCO. It is up to the CDSCO to decide whether it is a regulatory or a non-regulatory. They have to answer within 1 month. If they don't, you don't get any reply within 1 month, you presume that no permission is needed, you can go ahead. Otherwise, for all other academic trial, you don't have to go to the drug controller anymore, but the ethics committees have been given the responsibility now. So that means all the approved academic clinical trial now should be conducted in accordance with the Icmr National Ethical Guidelines. That is what is important now. The chapter 1 and 2 is all the preliminary ones. The chapter 3 of the new rules talks about ethics committee for clinical trials, bioavailability, bioequivalence. They have given the composition of these So according to this, there should be minimum 7 members in the committee. There has to be 1 lay person, 1 woman, 1 legal expert, and 1 independent member. These are there in addition to medical, non-medical, scientific, non-scientific. So these are there. So that means these 4 are necessary, and you can have 3 more members from the medical and non-medical scientific communities. But then they also said 50% of them should be institutional, 50% should be non-institution. But the member secretary is always from within the institution as per these are all from the Icmr guidelines. The chapter 4 is very important because this talks about ethics committee for biomedical and health research. And here we have to follow the Icmr guideline, which Dr. Roli has already spoken, so I'm not going into the details. So you can see that the new drug clinical trial rules gives an equal status to the Icmr guideline as far as the biomedical and health research involving human participants, including the socio-behavioral research. Chapter 5 talks about the permission which is needed for clinical trials and what are the timelines it is given. So it says that within 30 working days, the CDSCO will give approval. And if the drug is approved for outside India and first time coming into India, then it means it may take 3 months time. Within the 3 months time, the approval will be given. Chapter 6 talks about compensation. So compensation details are there. What is the medical management? What is the responsibility should be given? And how do you do the medical treatment and the payment details? And they've also given in detail the compensation calculation in the schedules. But as far as they've also talked about the compensation for biomedical and health research, which is called the Rule 43, which says that you have to follow the Icmr guideline. So Icmr guideline also talks about compensation mechanisms one has to follow. At the moment, there is no strict calculation, but we accept the same calculation about the CDSCO, but then every ethics committee has to look into the what is the application of that which has to be done. So Icmr also gives provision of medical management and the compensation, and so we'll have to go into the details about that. Now, there are, as I said, 8 schedules. I will not have to go into the detail, but each schedule gives the details about the various principles and the practices and the procedures, including the post-marketing assessment, the compensation, what do you mean by license, and then what are the registration procedures which are there. The SAA reporting, which is there earlier, the only thing in the new rules, what they have done is, as far as the investigator, sponsor and EC reporting, the timelines have not changed. Within 14 days of knowledge, one has to report, and the ethics committees have to report within 30 days. The change which has been done now is the SAE expert committee under the drug controller will now give the recommendation within 60 days. And similarly, the payment of compensation also at amount which will be the payment which has to be done within 90 days now. The registration of the ethics committees, of course, that's another big area. There's a lot of confusion which is going on at the moment. All ECs that approve regulatory clinical trials should be registered with CDSCO since 2013. Now, this registration is valid for 5 years after registration. However, from September 2019, the DHR has started their registration as per the new NDCT rules. Icmr ethical guidelines and come into existence. Then the DHR has announced, and this registration has to be done from September 2019. Initially, they are giving a provisional registration for 2 years, and afterwards it will be extended for another 5 years. There are many questions being asked about whether you should discuss register both, and we'll come to that in the question and answer session. The rule gives very clearly when you are registering, what are the details you should provide. As of date, there are 1,462 registered ethics committees under CDSCO, out of which 14,433 have already undergone re-registration. Okay. Now, similarly, under the DHR Ethics Committee Registry, which is called the NCDIR BHR, National Ethics Committee Registration, a web portal has been set up by the same in consultation CDSCO and CDSCO, and this is launched in 19 September. And as of now, that is the latest till 28 October 2020, 345 ECs are registered. Here also there is a checklist of items which has to be followed for registration. Till now, since there was only the CDSCO registration was existing in 2013, as you can see, there were more than 1,000, almost 1,500 ECs are registered. But if you look at the accreditation part of it, when the registration started, they also gave the responsibility to the National Accreditation Board of Hospitals to do accreditation. Why do we need an accreditation? Just having an ethics committee as per the Icmr guideline or as per the CDSCO is not enough. The functions of the ethics committees, of course, have to follow the guidelines. That is there. You have to follow the GCP guidelines and the Icmr guideline. But what is important is that what is the quality assurance which is there in the ethics committees? What is the quality improvement which is needed for all these registered ECs? It's not enough that you are a quality minded committee, but you have to also see the quality is continuously being maintained. It's kept on improving because there are so many new things that are coming up. So quality assurance, those people who are involved in quality standards, you know that quality assurance and quality improvement go hand in hand, it's necessary. So as far as the ethics committees are concerned, identifying the standards for ethics review, what is the benchmark performance, what are the best practices internationally which is available, functions and processes, how do you adapt them to the local needs, and how do you continuously do self-assessment is what is very important. And all these come under the quality assurance and quality improvement. So for that, just registration is not necessary enough, and you have to go for accreditation. So accreditation strengthens the human research protection programs. It promotes standards of quality and it encourages institutional ethics committees. Institutions have a commitment to the scientifically and ethically sound research with continuous improvement in their ethics committee functioning. So at the moment, we have 3 accreditation programs in the world. In India, we have the National Accreditation Board of Hospitals, to whom the responsibility was given by the CDSCO. We started in 2017. So we have so far 156 ethics committees in the country, which are accredited by the NABH. The CITCR is a strategic initiative for developing capacity in ethical review. I'll say what is CITCR now. We have 17 institutions. It's an international recognition program. The other one which is there is the AHARP, is the American registration program, which does accreditation of institutions, investigators, and the ethics committees in as of record till at the moment. Earlier we had about 6 or 7. As of the record, as I checked yesterday, there were only 3 from India which are under the AHARP accreditation. The NABH accreditation has certain standards by which they do, and as I said that so far 156 have reached. In fact, the drug controller had announced earlier that by January 2019, all the registered ECs have to be accredited by NABH. But then it didn't happen. You can imagine why it didn't happen, because all the ethics committees are registering, but majority of them are not doing any clinical trials, regulatory clinical trials. So when they are going for re-registration, many of them are not getting re-registration also, as they are not doing clinical trials. And then it has realized that in spite of all this, out of 1,460, about almost 1,500 institutions, only 156 in the last 3 years have been accredited. So accreditation is something which is very important. So NABH, the other institutions have realized that there's no need for them to go for NABH accreditation, so they are not going. But however, any accreditation sets the standard for the ethics committees. The other one, as I said, the CITCR is a strategic initiative for developing capacity in ethical review. It's a one which was started all over the world. We have the forums in the different. The first one was FERCAP for the Asia Pacific region, where we are all members. And we have for the one in the US and Canada, one in the Latin American, South American countries, one in Africa and Europe. And all these forums, They also do a accreditation ethics committee. We don't call it accreditation, we just call it recognition. We recognize an ethics committee as a best performing ethics committees. They also look at certain criteria like the NABH, there are also criteria. They look at the structure, the function, the SOPs, they observe the board meeting, checking records, progress of reports, looking at the archival process. In the country at the moment, we have only 17 ethics committees who have undergone this process again and again. So that's all as far as the presentation on the registration and the accreditations are concerned. And so this is a very big topic. There are many questions which had come even before by the registered participants. Even now in the chat box, many questions are coming related to all these things. So one has to understand that these are all the procedures by which we have to go to see that whether we are maintaining the quality and have a committee, because committee members keep on changing. You have to be registered, re-registered, accredited, re-accredited and re-recognized. And thank you all for this patient hearing. And as I said, under the Asia Pacific program, we have the Forum for Ethics Review Committees in India, which is the FASI, which I represent as the president. And so we have been helping the institutions to go through the FERCAP recognition as well as the other institutions. And so, of course, we'll now see that what are the details. Later on, for those who are interested, you can contact us for any further information in that. And thank you all. And I hand over to you, Shilpi.
Thank you, ma'am. Thank you so much for a cogent and influential session. It was indeed a very engrossing lecture and left us wanting for more. Thank you so much, ma'am. Moving ahead, the next session for today is on ethical issues in epidemiological research. And to provide eloquent insights, I would like to invite Dr. N.K. Arora, sir. He is the current executive director of the Inclin Trust International since 2005. He is a known public health expert in India and is extensively involved in policy making, program planning, implementation and evaluation of public health programs at both national and international level. He chairs the NCCPE Secretariat, that is National Certification Committee for Polio Eradication for Government of India, and also heads National Verification Committee for Measles and Rubella Eradication Program in India. He is a member of WHO Global Advisory Committee on Vaccine Safety and WHO Immunization Agenda 2030 Monitoring, Evaluation and Accountability Working Group. We welcome you, sir. Indeed, an honor to have you with us today. Over to you, sir.
Thank you very much. I'm indeed honored to be part of this whole process, and I can see, I mean, to be, I would say, being mentored by Professor Vasantha Muthuswamy, who is almost like mother of ethics in this country. So thank you very much, Vasantha. So I will speak to you about. So I will try to share and try to kind of sensitize you to some of the ethical issues in epidemiological research. Dr. Prashant Mathur initiated this whole process through his registry network, which probably is one of the largest in the whole world. The extensive network which has been created, and it is almost like a example for many even developed countries how to establish and then run these registries. So I will talk to you about ethical issues, some principles of ethics, key points that need to be considered in epidemiological research, specific challenges, and issues related to informed consent and waiver, and some examples of research translation and how ethics issues were taken care of in those years. So public health has achieved several milestones in India. And I'm sure probably all of us who are present would be remembering that in 1977, smallpox eradication occurred. Polio eradication certification took place in 2014. India is now eliminated maternal and neonatal tetanus in 2015. And public health and public health research both played a stellar role in achieving these national milestones, and in turn which have also contributed to the global moving ahead in public health. And all these were achieved by epidemiological research, which is integrated into clinical systems as well as health systems. So public health has to be seen in a context. So when we talk about public health, it is both individual health and population health thought through together. The public health occurs in a context where there is government rules and laws, ethics, public opinion, and then international standards. All these are working simultaneously, and therefore we need to look at this issue. While clinical trial we have heard, but public health has a much larger impact, and therefore we need to be very cognizant of the context. Now, when we are talking about epidemiological research, we need to keep almost all the issues simultaneously in focus. This includes medical ethics, which is patient-centered, it includes research ethics, which is subject-centered. But the most important, when public health is talked about, it has to have population-centered focus as well. And this balance has to be kept. The other point which Dr. Roli Mathur made, and which is very important, how to differentiate public health and epidemiological research from public health practices. Because there are a lot of commonalities, be it surveillance, program evaluations, registries we heard. Registries can be both part of public health as well as part of research programs. Then all the other issues of outbreak, pandemics, screening, immunization, they need to be seen through, and this differentiation is important, particularly when we go in for ethics issues. Responsible conduct of research is important from all types of research, whether it is clinical trial or it is simple reporting of a case or epidemiological study or intervention. In every field, this responsible conduct of research. And when Roli was telling us, I think this separate chapter is very important, and we need to really look at it very carefully, because it talks about in a very comprehensive manner how the 10 issues of epidemiological research have to be taken into consideration. Some of the important issue is this issue of promoting solidarity and reciprocity. Now, this is something, just to give you an example, that during this COVID pandemic, the health system has played a stellar role in taking the whole the interventions and looking after the community. And therefore, today, when client recipient priority was being done, the whole health system, the police and the army and the municipal workers, they have been put as the foremost in a priority. So this reciprocity is very important. The second component is, which we need to keep in mind, is issues of community engagement and benefits to the community. And community engagement is just not a kind of talking to the community leaders, actually directly establishing linkage with community is important. And another very important component is this accountability component. Whenever we do research, the investigator is accountable. And there is now, as you can see, more and more, even in publications, they want access to all the raw data. And most of the journals ask for that kind of a transparency. This issue of data ownership, I will just take a brief comment on this, and that is that the data is owned by the subject or the patient who has whose data it is. So the whole concept of data ownership is now talked about as data custodianship. So all the investigators, institutions are custodians of data. The data is owned primarily by the individual of who has provided that data or whose data is there. Now, some of the key points to be considered in an epidemiological research are that there should not be any harm in whatever is being done. That is fundamental, because when we do large studies where populations are involved, the harm is something very important. And for example, this issue, which you see the photograph on the right side, where the individual's hand is damaged, and it is because of poor injection practices. And similarly, issues of, you have heard about wrongly removing the kidneys and operating on the wrong sides. All these are issues. So I'm not talking about clinical care, I'm talking about in research also, these issues happen, and one has to be extremely careful about that. This point is, again, I would like to redefine and try to discuss this issue, that defining boundaries between public health research and practice. It is a critical challenge, because public health practitioners in government government agencies systematically collect various kinds of data, and the various objective and methods of these practice-based activities often overlap with those of researchers. So whether it's surveillance, disease control, program development, evaluation, for all, the methods remain and objectives are very overlapping. So how do you differentiate between research and non-research? It is primarily the intent of investigator as an essential part. What the practitioner versus investigation, what are they trying to do? And if the primary intent is to contribute to generalizable knowledge, vis-a-vis, if the intent is to take care of the local issues where the data is being collected or where the system is operational, that issue is very important. So if in the research, it's primarily to generate generalizable knowledge, and here an IRB oversight is required. So when we talk about public health ethics and public health research ethics, broad six principles are kept in mind. The coloring difference is not, the purpose is not to highlight anything. It is just to differentiate the 6 points. The first point is, what are the public health goals? The second is, how effective is the intervention or policy or program? What are the known or potential burdens of the program? How can burden be minimized? The fairness with which the interventions are implemented, and how can public health benefits and accompanying burden be balanced? This whether we are talking about risk benefit, cost effectiveness, and all those issues are to be taken care of. So I'll take them one by one because this is a fundamental issue when public health activities and public health research is to be taken. The goal of any public health activity is reduction of morbidity or mortality, is to have social benefits, and interventions often are targeted to one set of individuals in order to protect other citizens, or programs to protect individuals themselves. So, for example, HIV screening. HIV screening is done not only to protect the person who is having HIV, but also to decrease or interrupt or reduce the transmission of HIV. We may talk about health education on cardiac risk reduction, or individuals will have fewer heart attacks. So you have education programs. You have immunization program is another very good example where there is individual protection as well as population protection is there. Then we have individual seat belt laws or speed limits, which is primarily for the individuals concerned. So there is a constant issue of balancing between individual versus a larger population and community goods. The effectiveness of interventions has certain assumptions. And these assumptions, the ethics committees have to think about how good are these assumptions and whether these assumptions are appropriate for the program to achieve the stated goals. So, for example, if we are talking about a cardiac risk reduction education program, and the goal is to reduce fatal and non-fatal cardiac events. So, assumption may be, assumption in most of these is that this program will reach individuals at risk. Individuals will learn the message and they will change the behavior, resulting in fewer cardiac events. That's the assumption. But in reality, whether education program really is effective in transmitting information and changing the behavior, probably no. The same is true. So most of the chronic disease have this issue and this challenge, and therefore ethics committees have the also responsibility to see that unless they are convinced that these assumptions are appropriate, will make a improvement and a movement towards the right direction, one has to look at the value of that kind of a research. What are the various burdens or risks of public health programs and research? The privacy, confidentiality is as it is important for any kind of other issues. Liberty and self-determination. Now, this is this point of undue inducement was talked about, and that is very important. That how we are going to take care of those issues. Justice. Now, if the intervention is targeted only to certain groups, now that has to be seen whether it has a larger impact or it is to benefit only particular group. So equity, justice. There are clinical and psychological risk involved and social risk involved. So when we do qualitative research and we go into in-depth interviews, we try to find out those components which you may say that the person, there is no risk involved, but you are basically entering into those areas or those aspects of life or of an individual which may have potential to stigmatize or ostracize the individual. Also, some are very personal information may be, and this may lead to both medical risk as well as social risk. So you must have seen just today morning that I think Prince William's had corona infection in April, but nobody was informed. The reason is that the reason told was that it might create public scare at that time. It was early in the epidemic. So there are all kinds of factors where whether you share the information or not. So it is very important. These are all risk. Disadvantage or privilege through research participation. Again, if my research project brings in certain special privileges, for example, I do a vaccine trial in a particular community, and later on they become one of the first, or they are the only community which gets COVID vaccine on priority basis, or only or they get it even when there is shortage. And now one has to look at those issues. Cost to health system. Issues of reputational or financial harm to institutions who are involved. There may be some research which may have adverse influence or negative influence on markets. So a recent example was this, what is Gilead's remdesivir. And this medicine was not being used. There were some initial studies which showed probably it is beneficial. Their share prices rocketed 10 to 15 times, and now there are these solidarity trial has shown that it has no meaning. And finally, a very important component is that research findings, if they are not implemented into health policy or practice, and there is no benefit of research, such research ethics committee should. So one of the very important aspects of when evaluating the research should be whether there is a potential for, or there is an effort for translation this research. If it is not there, one should really push the investigators to see why they are doing this research. How can burden be minimized? And ethical requirement is to determine if the program could be modified in ways which minimizes the burden. And disease surveillance is a very good example. So if I have unique identifiers versus line listing and there is complete addresses available, what kind of, how can I see that the possibility of minimizing? So depending on the objectives, I can say, so for in registry, if I have to do a cross-sectional study, then unique identifiers are not required. The name and the unique identifiers are, one has to see it. Then you can have a coded identifier. But if I have to follow these registry individuals, those who are part of the registry, and they have to be followed up for survival and other things, then I need names. So one has to look at this to see how I can minimize the burden and the risk. And then finally, the last 2 points are implementation fairly and the benefit and the risk involved. So clean water cannot be limited to one community alone. Another way is that if I am doing a study and I'm trying to find out neurodevelopmental disorders or some physical, mental, emotional handicaps, and this is being done in a particular community or in, so one has to see this whole issue of principles of distributive justice. And this component one needs to really discuss upon and to see that it should not either stigmatize communities or undue advantage to a particular thing. And then, as I said, risk and benefit have always to be weighed simultaneously. So selection of a study design will depend on the type of research questions. And so ethics committee has the responsibility to see that the for the a particular research question, The appropriate design has been identified. The importance to public benefit and focus on benefits rather feasibility. Although feasibility is important, but benefits are equally important. And then the whole study design, whether it is sample size, representativeness of the population, and other issues have to be kept in mind. And those 6 principles have to be seen through by the ethics committee. If required, a checklist may be formed. And all research protocols should be reviewed and approved by an ethics committee. Even for when ethics, when consent waiver is to be given, even their ethics committees are to be involved, and they must look at the protocol and review it. Now, some of the unique issues of a particular type of issues which we are talking about. The first is surveillance, program monitoring, and evaluation exercise. They may be exempted from ethical committee review, particularly if the purpose is for national program improvement or refinement. And a large number of stakeholders are to be interviewed across geographic sites. But that does not mean that you don't submit it to the ethics committee. Ethics committee would say that it is exempted, and you are exempted from consent taking, individual consent taking. And but ethics committee should ensure that the knowledge so generated is generalizable, it has wider impact, it is scientifically sound, interpretations are properly done, public health values are maintained. Any potential harm inherent in the protocol has to be very carefully looked at, and then only allow that. Demographic surveillance sites. Recently, the country has set up almost a dozen new demographic and development and environmental surveillance sites. So when as part of 2017 Icmr ethics guidelines, one need not have permission for ethics review. Basically, state or national authorities are to be approached and permission to be taken from them. However, for all surveillance sites, data should be stored in an encrypted format with minimal access.